All right, so we will begin our discussion on the conditions of the reproductive tract. So, what is the normal function of the reproductive system? The entire goal of this system is that the male and female sex cells are able to come into contact with each other. Because of that, we can roughly divide the reproductive system into two parts. You have the gonads, which produce the sex cells and are primary producers of the sex hormones that separate male from female. And then we have ducts. The ducts are the transport for those cells in order to allow them to come in contact with one another. So one of the first things to talk about when we talk about reproductive diseases is STDs. We're only going to talk about a couple of those here because really we've already talked about some of them in infection, and because in reality a lot of these are treated the same. They have slightly different symptoms, especially between men and women, but typically treated the same. But the ones that we're going to focus on, at least in this lecture, there's a lot more mentioned in the textbook, but in this lecture we're going to talk about the ones that tend to have more severe consequences if they are not treated or remain chronic. So the first one is syphilis. Syphilis is a chronic systemic condition. It has multiple stages, and it needs to be treated early on. If it's not treated initially, it will eventually spread through the body and will involve the skin, it will involve the nervous system, and it is incredibly dangerous. It can cause things like gonococcal arthralgia, and other nasty conditions, especially with the nervous system. So remember, syphilis is caused by a spirochete bacteria called Treponema pallidum. It is you're exposed to it through direct sexual contact and infected bodily fluids, which includes the contents of lesions on the skin. Typically, the lesion is called a canker or chancre, and it is painless. Within 1 to 2 months, it will heal over, and the causative organism has actually spread through the entire body and can affect just about everything. Once it spreads systemically, you'll get things like fever, headache, aching joints, mouth sores, rashes on the palms and feet. There's also a latent period here, and the scariest part about syphilis is that the latent period has been shown to be up to 40 years after the initial infection. Once you get into the late stage, you have lesions called gumas. They invade organs themselves, and it's an incredibly dangerous condition because it is destroying organs. If an individual is pregnant, the fetus is very much at risk. They're also if they do end up being delivered, they could have multiple abnormalities. When you are looking to diagnose this condition, we're basically looking for 3 things. We're going to do a VDRL, which is a venereal disease research laboratory test, and a rapid plasminogen reagent test, an RPR. Also, sometimes they'll take bacterial smears and try to grow the bacteria and look for spirochetes. Spirochetes are not very common to infect people, which is one of the things that makes syphilis stand out so much. So most common antibiotic use here is penicillins, but they might also use things like doxycycline, azithromycin. Doxycycline is a very popular one for STDs, tends to work very well for many of those. But again, it's important to treat early and ensure that it's treated properly, because long-term systemic complications will happen. A lot of patients that have had a diagnosis of this condition, they receive continued follow-up testing for at least a year. Another common thing to talk about, HPV and cervical cancer. These two things are together. And in fact, we always talk about just cervical cancer, but human papillomavirus, HPV, is actually able to, or is associated and can directly cause cancers of so many different parts of the body. What is very difficult about HPV is that we do not have any drug available to treat it currently. Some are in stages of development. Some look more promising than others. We'll have to wait and see. The virus, of course, does spread through unprotected sexual intercourse, but can also occur. The spread can also occur through close physical contact with an infected area. It can also spread through contact with digital contact, so with hands. It can also spread with oral contact. It can be incredibly spreadable, incredibly dangerous, especially for individuals that are not vaccinated, which is why HPV vaccination is actually recommended for everybody. Female children are typically recommended to get it earlier on, between the ages of 11 and 12, but males are also susceptible to HPV, and they do tend to be essentially carriers of it, which is why males are also encouraged to receive the vaccine for it pretty much anytime after the age of 9. The vaccine does not replace other proper preventative strategies for other STDs, though. And it's also important to continue to receive proper annual evaluations by a medical practitioner, too. Sexual dysfunction is a very common problem that men and women seek help from their medical providers. It could be, there's so much that goes into it. That's well beyond our discussion here, but the idea is that essentially from the basic human sexual function standpoint, we're seeing some sort of change. One big thing that they do talk about to diagnose a true sexual dysfunction, though, is, again, you have to rule out any psychological factors. So there are drugs that exist that cause sexual dysfunction. Plenty of them do. In fact, some of the most common drugs that are prescribed in the United States, things like antidepressants, SSRIs, are very, very known for causing this type of dysfunction. It can be incredibly detrimental to people's lives and their relationships. But that's a completely different problem than what we're talking about here. We're talking about an actual change in the physiology. Okay, so this could be something like a man that has a cardiovascular disease. That, you know, is at risk for issues with stroke, heart attack, etc. They've been told that they shouldn't take drugs like sildenafil, which is Viagra. They need to avoid drugs like your phosphodiesterase inhibitors, which are used for arrhythmias. Things like hyper and hypotension, liver and kidney disease, anatomic deformities can all cause this. And certain things are more common than others, and certain things are more treatable than others. So one of the most common types of sexual dysfunction is on the male side, and that is erectile dysfunction or impotence. It is the most common form, and there is hardly any males that will not experience this at one point in their life. Okay, there's many different reasons but it's often temporary and transient, but in some individuals, it can be a very chronic problem. It's typically related to other underlying medical conditions. And the one thing you'll notice about all of these conditions here is that you're going to see issues where the arteries that supply blood to the penis are unable to properly supply blood. Okay, so you don't get the same responses necessary to sustain an erection. You can also see in some people, like with diabetes or other neurological issues that are affecting like the lumbar nerve plexus, you might see things like people that ride bikes, especially males that ride bikes a lot, people that cycle a lot. They don't have a properly fitted saddle or seat. The compression on the gluteal region can actually interrupt the blood supply through the internal pudendal artery, and it can also interrupt the nerve supply through the pudendal nerve, and that can cause both of those things cause these same issues. It's essentially vascular and neurogenic claudication, but at a much smaller level and in a very specific area. I mean, it's also possible to have trauma-based incidences as well that can cause this problem. Diagnosis, though, is very straightforward and is primarily based on history and talking to the patient. You can do certain lab tests, especially if you want to rule out other underlying conditions, again, like the diabetes. You can do things like EMG testing. You want to test testosterone level. Testosterone for both men and women is a key part of sexual drive. Okay, we always talk about how men have more testosterone than women, and that is true, and how women have more estrogen than men. Well, that's not always true, but women still have a lot more testosterone in their bodies than they do estrogen. Okay, that is something that's often overlooked and something that is often poorly understood, especially by medical practitioners that don't really deal with these types of issues. Testosterone is just as important for a female's sexual health as it is for male. Okay, so again, history and physical exam are the two major things here, and especially with a male patient, you're gonna get all the information you need just from talking to them. That's for a lot of those male patients. They're showing up to the doctor's office. That is the chief complaint for the day, right? This is a problem for them. That is why they are explicitly there. So treatment, again, underlying cause. Is there another condition causing it? Is there a psychological issue? Do they need counseling? Is there reduced testosterone level? Do they have some sort of anatomical problem, something like a Peyronie's disease, which is a excess growth of connective tissue that causes a deformity and changes the way that an erection could even happen. There's all sorts of things that can cause this type of condition. So you find that underlying cause and you treat it. Now, if you're going through all this stuff and you're just, there's no psych, there's no medication causing it, testosterone seems okay, there's nothing else going on, then you go for the impotence-based drugs, things like your sildenafil, your vardenafil, and tadalafil. Those are Viagra, Levitra, Cialis, right? So those are the big ones. Those have been around forever. But you'll also notice that these drugs are actually also used for other conditions. That is something that I also mentioned in the cardiovascular chapter. These were actually discovered as part of the research into cardiovascular conditions. And in fact, you will see women even given these drugs for things like angina, right? Because these drugs do exist to help increase blood flow into the body. Now, if I recall correctly, the dosages that are given for this purpose that we're talking about now for erectile dysfunction, they're actually much higher. Okay, so, but it is something to continue to watch out for, because there is a link that does exist between erectile dysfunction and coronary artery disease. So if a patient is presenting with ED, it's important to check for the risk factors of that as well, because there is a lot of overlap. It's a vascular problem under the surface. So infertility. Infertility is a very complex topic. Very, very complex topic. So it's essentially defined as the involuntary inability to conceive while having regular unprotected intercourse. When doing that within a year, 90% of couples should be able to conceive a child. Of that 10%, about just shy of half is thought to be related to the male, just shy of half is thought to be related to the females, and then at least 10% is essentially an unknown reason. Okay, when this happens, there are doctors who specialize in fertility. They will do very thorough medical evaluations, lifestyle evaluations, all sorts of things. And it's very important that you go through with all those testing for those patients that have that problem. So male infertility. This is somewhere between 40 and 50% of all cases of infertility. It's often idiopathic. But what we see is one of two things. There's an insufficient number of sperm, or there's an inadequate function of sperm, primarily motility. That's the ability of the sperm to be able to actually, essentially, quote unquote, swim, right? So if you have too little, or it can't actually get to the egg, that's a problem. Now, there are other cases where there are congenital disorders that can cause both of these things. And there's also environmental factors and other types of medical conditions. One of the greatest environmental factors that impacts male fertility is smoking and environmental pollutants. Those two things are huge at causing this. Causes of female infertility. So one of the most common causes of this that we see in the more younger population is failure to ovulate, especially in younger, highly active patients. They're essentially experiencing some form of amenorrhea, but there's also other reasons to not ovulate at all. You can have endometriosis, which we'll talk about later, scar tissue formations, blockages in the fallopian tubes, more congenital disorders, psychological distress is also big. And the same thing can be said for male fertility too. Psychological distress is a major inhibitor, but there can also be things like tumors. Females can actually create anti-sperm antibodies, which is obviously a major problem as well. With the diagnosis of male infertility, the biggest thing is physical exam and a semen analysis. You've got to find out what's causing the issue with the sperm and go from there. For female infertility, it's a much longer, more complex situation. You need blood tests at different points in the menstrual cycle because you need to chart out the menstrual cycle. You need to do examination of the fallopian and uterine cavity. This is often done with specialized radiography. They also do ultrasounds, etc. Laparoscopy is useful for doing an exploratory look to rule out things like endometriosis, which again we'll talk about shortly. But this can be a very expensive and time-consuming process. And male and females both need to undergo effective counseling. They need to undergo effective patient education. There are also a bunch of different things that exist, and depending on what type of problem that they find, there are ways to help assist with it, such as if the male has insufficient sperm count or insufficient sperm motility, artificial insemination does exist, and that essentially will take the sperm and introduce it directly to the egg, which increases the likelihood of fertilization. It makes it much, much, much higher. Okay. Now, just because fertilization has now occurred doesn't mean there might be a new problem to overcome in the future. So, moving on. Male reproductive diseases. Most commonly affected organ is the prostate gland. Symptoms of prostate issues are going to be urinary problems, pain or swelling of the reproductive organs, and sexual dysfunction. Now, the gland can become enlarged due to bacterial infection, can also become enlarged from benign prostatic hyperplasia, which is something else we will talk about. Another thing is the varicose. So with a varicose, you get one testicle becoming abnormally distended due to a blockage, typically of a vein. That expands within the scrotum, and you have that enlargement. The left side is much more commonly involved, and this is because the gonadal vein comes from a different location on the left side of the body, and the same thing is also said for the gonadal vein in a female. Remember, when you look at your abdominal cavity anatomy, your aorta descends through the abdomen along the left sides, left anterior of the vertebral bodies. Your vena cava ascends along the right side of the vertebral bodies. On the right side, the gonadal vein will come directly off of the vena cava. But because the body does not like to have things cross midline, the body likes to develop from midline out. The left-sided gonadal vein actually comes off of the left renal vein, or goes to the left renal vein, I should say. And that then goes to the vena cava. So there is essentially, with the direction that it runs, there's more anatomy involved that would potentially cause an issue, cause a blockage, cause compression, etc. This is typically a younger condition, something that happens as a teenager or a younger adult. So treatment, they have special fitting supports to wear that are either built into underwear or that you wear separately. Sometimes they do surgical removal of the vein as well. So benign prostatic hyperplasia, this is very common in men 50 and older. It's non-malignant, non-inflammatory. The hypertrophy, there is hypertrophy of the prostate. It causes compression of the prostatic urethra and can even swell up enough that you get a relatively severe urinary blockage at the bladder. So remember that the prostate gland sits just on the inferior side of the bladder. These individuals get a difficulty starting urination. They have a weak urinary stream, and they have the inability to empty the bladder fully. Typically here, you want to rule out things like infection, but the PSA test, prostate-specific antigen, is one of the biggest tests here because it will help differentiate out BPH from prostatic cancer. So really, treatment, there are some medications to take to help relax muscles around the prostate and in the prostate and shrink and enlarge prostate. Sometimes, if it is bad enough, they will perform surgery to remove the prostate or part of the prostate that's causing the problem. Prognosis is typically fine, but again, it's important to watch for infection because there is a slightly higher risk. So prostate cancer is incredibly common. It's one of the most common cancers. Pretty much, if you're a male that's 70 or older, it's not a matter of if you're going to have prostate cancer, it's a matter of when you're going to develop it. It grows so slow, though, that it's typically not a concern, especially in that older population. Now, our slide here says men over the age of 45. Well, unfortunately, when it is more aggressive, it does tend to affect younger individuals. Like most cancers, diets high in animal fat are more, you're more likely to have this condition. The symptoms, again, you basically have a tumor of the prostate cancer. It's just the symptoms are identical to BPH. Diagnosis, so just like BPH, there's a digital rectal exam. You do a PSA level, and if there is an issue, they do a biopsy where they take multiple very small biopsies from the prostate. It's possible for them to completely miss the tumor of the prostate. May or may not be a major issue, especially if the individual is older, because again, the likelihood of prostate cancer actually causing significant harm to somebody is incredibly low. But once you know you have it, it's very important to monitor regular blood work and watching the physical condition of the patient. You want them to be active. Prostate cancer loves to spread to bone if it does spread. Doesn't spread a lot, but bone is a major, major issue. Next is testicular cancer. It is one of the most curable neoplasms that exists, but it does have significant physical and emotional impact on a person that has it. Almost all of these are from germ cell tumors. They're typically classified as seminomas and seminomatous germ cell tumors. The big thing, though, is swelling of the local region as well as enlarged lymph nodes in the same area. One of the greatest risk factors for testicular cancer, but also other types of cancers that we're going to talk about, is family history. Okay, so whether your mother or father had it, when I say mother, it would be more like ovarian cancer. Even if your mother had ovarian cancer, you're still at risk for testicular cancer because of that. There are some interesting correlations between things like Klinefelter syndrome and Down syndrome, where those individuals are at greater risk of developing it. Big thing here, though, is a physical exam to detect nodules. They're typically firm, non-movable, and relatively easy to feel. They typically do not biopsy them, though. There's a worry with certain types of tumors that a biopsy will cause more harm than good. So generally, they do not do a biopsy. Treatment, in this case, chemotherapy, surgical resection, and radiation therapy. Prognosis is actually decent with this. You might even see radical removal of a testicle. It's much safer for that to happen, right? So it's going to essentially prevent the spread of it. But when those people have that, they're still going to undergo other treatments like chemotherapy and radiation to ensure that if there has been a minor amount of it that has spread, that they actually are dealing with it. So female reproductive diseases, there's really two rough ways three ways to classify these. There's your microorganism related, your tumor related, and then your miscellaneous guys, right? So these could be the stuff related to congenital disorders, things that are related to medications, dysmenorrhea type conditions, etc. So first one is premenstrual syndrome. This is the constellation of physical and emotional symptoms that are related and caused by the fluctuation of estrogen and progesterone and how those impact neurotransmitters in the brain as a female moves through their normal cycle. Some of the things that are associated with this are stuff that you see here, but we also have fluid retention, changes in sodium excretion, which is actually the cause of the fluid retention as well. Bloating, abdominal pain, etc. There is a different type of disorder called premenstrual dysphoric disorder, PMDD, which is different than PMS and is something that you would need to rule out because it's basically a hormone-caused psychological disease. So you might see those individuals being given antidepressant medications or other things like birth control pills to help even out the cycle, etc. So first thing to talk about is amenorrhea. Amenorrhea is the absence of menstrual periods. It can be a primary condition. It can be a secondary condition. There really is no symptoms. The only thing that is observed is the lack of cyclical bleeding. Now, no matter what, a proper physical exam does need to be done for this patient to help determine what the actual cause is. So you could just have something like a late onset puberty, you could have physical abnormalities, and you can have hormonal balances that directly cause these problems. It's important to rule out things like, physical obstructions, endocrine disorders, other types of congenital anomalies. And this would primary amenorrhea are not suspected until a female has reached the age of 16 without the onset of menarche. So secondary amenorrhea. This is essentially hormone-related issues. So pregnancy would be considered secondary amenorrhea. It's very normal not to have a cyclical period during pregnancy, okay? There's emotion that ties into this. Illnesses. With a major enough illness, the body really starts to alter the way in which it metabolizes tissue, and the monthly cycle that a female goes through is actually very energy demanding. Pituitary tumors obviously will have a major impact on this because you have your hypothalamic, pituitary, gonadal axis. There's essentially an axis for everything that involves the hypothalamus, pituitary, and all of the downstream endocrine organs. Thyroid diseases are also a big thing here, and excessive athletic training. This is kind of on its own thing now. We've kind of pulled it away. They used to call it like the female athlete triad, but we've kind of reclassified it as a condition called RED-S, which is relative energy deficiency in sport, because we have since found that while males don't have cycles the same way that females do, with outright changes with physical manifestations, males' hormones do cycle, but in a very different way. And if there's not enough energy availability, either because of a eating disorder, too much athletic training, or a wide variety of other issues, the symptoms are actually very, very similar between males and females. So we've been calling that relative energy deficiency in sport as a more proper name for both men and women for this. It just so happens secondary amenorrhea is a symptom of Rett-S in females. So diagnosis: you physical exam, blood tests, urine samples, and you may need various types of diagnostic imaging. X-rays themselves are not typically very useful here. You can find certain things that could cause amenorrhea, but ultrasound and abdominal CT tend to be the best thing. Treatment: you got to treat the underlying cause, but you can also do like hormone replacement type therapies here. Dysmenorrhea: now this is severe pain associated with menstruation. The pain typically is so severe that it is theorized to be able to cause the inability to perform normal daily activities. So there are underlying structural causes, but there are also secondary issues for this as well. So the key thing with this as well is symptoms usually end by the end of menstruation, right? So the diagnosis for this, though, can be incredibly time consuming again, because we're looking at a cyclical process and we need to see how that process is actually functioning as a whole. In a lot of these patients, it can also be incredibly psychologically debilitating. And it's incredibly important to involve some form of psychiatric health practitioner in order to help the patient develop coping mechanisms, okay? They need positive coping mechanisms, especially, right? Being able to actively be empowered to feel like there are things that they can do, because there are, right? And the same thing goes for any patient that has chronic pain. They need someone like that in their corner, and you can do a lot of work with just a handful of very simple, basic strategies for the patient. So treatment of this: non-steroidal inflammatories can be effective for some people. A lot of individuals find heating pads. In some cases, hormonal therapy or surgery may be necessary. With surgery, it's typically related to things like endometriosis, fibroids, or cervical abnormalities. There are drugs like progesterone receptor antagonist, but I believe those are still in clinical studies, and I don't believe one is currently available in the United States. So ovarian cysts. These are relatively common, and they are a fluid-filled mass, or semi-solid mass, I should say, that originate within or on the ovary. You'll see a picture of it on the next page, but there's two types. One's physiologic, which is caused by normal functioning of the ovary. And most of those are physiologic. And with that when that happens, you have the ovarian follicle growing an excessive amount, or a corpus luteum that persists too long. And remember, the corpus luteum is a stage that one of the stages that the egg takes as part of like the ovulation cycle, if we want to call it that. Neoplastic cysts, those are benign or malignant, but are not normal functioning cells, and they don't assist in the normal function of the ovary. So this is a pretty decent size ovarian cyst here. I have seen diagnostic imaging of individuals with ovarian cysts that are so large, they're actually touching their liver, for instance. They can get incredibly, incredibly large. Most of them are small and unnoticed, though. If they're big enough, you can have urinary issues. Sometimes the cysts can produce excess hormones. And they can also undergo torsion, similar concept like testicular torsion. There's a lot of underlying factors though that we have to look out to know when a ovarian cyst would be symptomatic or not, and it can be highly dependent on where the cyst is developing and the person, etc. Generally, though, this can be diagnosed on an ultrasound, but if they're too small, laparoscopy is going to be useful. So treatment-wise, small ones, there's not really much that they're going to do about it. If it's small, honestly, it's more dangerous to do a surgery to drain and remove the cyst if it's below a certain size, right? And that's something that, this type of practitioner would have a conversation with the patient about. Large cysts will be drained. Sometimes, if they are fully or primarily solid, they will excise them. If they are cancerous, then they will often receive surgery to remove them. Oftentimes, when that happens, a full or partial hysterectomy is also performed with it as a precaution. And that is because all of the female organs are typically, or should be, in a normal developed individual, contained within a structure called the broad ligament. And the broad ligament, again, connects all of the female reproductive organs together. The vasculature is within that ligament, and it's essentially a highway for cancer cells to be able to spread. So a lot of practitioners, just like the whole idea of a testicle removal when there is testicular cancer, they will go all out and they will remove everything that is deemed at risk. You might even see things like lymph nodes and appendix are removed alongside it. So next, endometriosis. This is relatively common. This is brought on when excess endometrium is found throughout the pelvis. This endometrium is the same endometrium that lines the inside of the uterus. The big problem is this endometrium is not in the uterus. It's deposited throughout the pelvic and abdominal cavity. And in fact, I've even seen cases where there has been endometrial tissue found on a heart, for instance. So as a female goes through their normal cycle, this endometrium responds in the same way. Okay? So symptoms, secondary dysmenorrhea is classic. There's lots of cramping and pain in the lower abdomen that lasts alongside menstruation. There's often infertility issues, pelvic pain with intercourse, and pain during defecation, especially if any of the large intestine is involved in the condition, which it often is because of how close things like the sigmoid colon and rectum are to the uterus. Also, because this will cause inflammation in a rather cyclical cycle, this can lead to scarring of tissues, including the tissue, essentially the tissue that this has been deposited on. Risk factors, family history is a big thing, menstrual cycles that are short, uterine structural abnormalities, and periods that last longer than a week. Diagnosis-wise, the only thing that you can really do is a laparoscopy. So it's what they do is they insert a scope. There is they fill the abdomen with a gas. They insert some scopes, and if they find endometrial tissue, they essentially cauterize it off and kill that tissue. Oftentimes, hormone treatments are the preferred treatment for younger patients. Now, it is possible to perform a total hysterectomy with salpingo oophorectomy as well. That's just a radical hysterectomy to remove everything, which can also help, especially if there's a lot of excess endometrial tissue. Those things are useful. Next is pelvic inflammatory disease. This is an infection, typically in a young, sexually active woman. Walking would be painful. Patient often has a shuffling gait, especially if an abscess has developed. These abscesses may or may not be palpable externally if they grow large enough. The concern with PID is that the severity of it is wide-ranging. It can cause no problem in some people, and it can be incredibly life-threatening in others. But this condition has your stereotypical infectious symptoms. So pelvic examination is a key part. An ultrasound to examine for an abscess. Lab testing, you're looking at your white blood cell count, so you're doing your complete blood count with differential. Typically, infectious STDs like gonorrhea and chlamydia are the main cause behind this, but they don't have to actually be STDs that cause it. Treatment is aggressive antibiotic therapy. You may use analgesics to help with pain, but if it is not treated, life-threatening complications can arise rather quickly. This condition also can cause fiber scarring and adhesions to form, which can increase the likelihood of infertility, ectopic pregnancy, and a lot of other nasty things. So next, menopause. Average age of menopause is about 50.5. But it's not considered premature until a female is younger than the age of 40 with onset. This is basically just the natural end of the natural cycle for a female. The body starts producing less estrogen, and ovulation becomes inhibited. You're going to see, because of the changes in these hormones, which also does include testosterone. Again, testosterone is incredibly important for female sexual health. Physical and psychological changes exist as well. Symptoms, you start to get a highly fluctuated menstrual cycle. Periods become lighter. They're less frequent. Hot flashes and night sweats. And then skin changes and vaginal dryness are also very common conditions. There's oftentimes psychological distress, depression, anxiety, sleep disorders, a loss of interest in sex. All of those things can also occur as well and are important to watch out for. So hormone treatment, you can have replacement hormone for this. There's also different strategies for helping with the psychological aspect of this that, it's really stuff we'll cover in the psychological chapter, but things like SSRIs, counseling, etc. And we have the obvious solutions for individuals who still wish to have intercourse but are experiencing pain due to, dryness. There are products that can be applied to the area to assist with that. So cervical cancer, we already mentioned this earlier, but most common types of this are squamous cell carcinoma and adenocarcinoma. Big thing to watch out for is watery and bloody discharge and bleeding between menstrual periods or after intercourse. Another big asterisk here is after menopause as well. Pap smear is the big way to examine for this. So again, regular routine pap smears as suggested by a medical provider are the thing to follow. Treatment. Typically straightforward. In the early stage, they will excise it via laser therapy, cryoablation, etc. With a later stage, they will try to excise as well, but they'll also use radiation, chemotherapy, etc. Prevention, primary way is vaccination against the human papillomavirus, as we already talked about. Ovarian cancer. Now, this is really the big one, as it accounts for more deaths than any of the other gynecological cancers. There is also an increased risk for ovarian cancer in females that have had breast cancer or a family history of breast cancer and ovarian cancer. There's also another condition called hereditary non-polyposis colon cancer that leads to an increased risk in ovarian cancer as well. Another thing that you have to be careful with as well is prolonged use of oral contraceptives, as those are linked to this too. Big thing to watch out for is enlargement of the abdomen. You get accumulation of fluid with ovarian cancer, but you're also going to see a lot of the same gynecological type symptoms as most other generic gynecologic conditions. So issues with menstrual cycle, painful sex, digestive disturbances, urinary incontinence, low back pain, etc. Any of those generic, and again, it really is often generic. And if a person is having multiple generic conditions over an extended period of time, like a couple weeks, that's when you definitely need follow-up, because while on the surface it might not be that big of an issue, it could be, right? And that's how things that are major problems, that's how they start. They start off as not a major problem. They are more treatable when it's not an issue. Generally, though, ultrasound and abdominal pelvic CT scans are very important. If metastasis is believed to be possible, they might even do things like a bone scan as well. Treatment-wise, hysterectomy, remove the ovaries, fallopian tubes, uterus. More advanced, radiation chemotherapy. Next, conditions and complications of pregnancy. So, again, the body changes a lot once it is pregnant, and there are risks associated with carrying a pregnancy. This is why prenatal care is always so important. So prenatal diagnostic tests, 4 big ones here. Amniocentesis, which is when they take they drain a small amount of amniotic fluid and analyze it in the laboratory. There's the chorionic villus sampling, or CVS. Again, that's another type of biopsy where they excise some of the placenta. And then there is a Doppler ultrasound that they use to produce a 3D fetal imaging procedure. I'm sure everyone is very familiar with what those look like. So, first thing to consider, ectopic pregnancy. This is when a fertilized ovum is implanted outside of the uterus. This is often life-threatening and is a medical emergency. Individuals will have incredibly high beta human chorionic gonadotropin, indicating that they are pregnant, but their ultrasound does not indicate anything is present in the uterus. So if it's not ruptured and not causing pain, then realistically what they're going to do is a series of ultrasounds to help try to find the location. And then eventually they'll do a coldocentesis, where they coldocentesis is another diagnostic procedure. And they'll actually go place a needle in the space behind the uterus, because that is often not visible on ultrasound, because ultrasound works by sending sound waves that bounce off of stuff. Well, if it's bouncing off the uterus already, guess what? It can't see what's behind it. Treatment is laparoscopic surgery, especially once they find it. They have to remove it. Okay, if it has ruptured, lost blood does need to be replaced. If it's not ruptured and it's early on enough that they're not super concerned about it, they will use a drug called methotrexate that you have likely already heard about in our immune system discussion to terminate the ectopic pregnancy. The body would essentially terminate it, and then at that point will break it down, and there should not be a major issue, but there still would be continued monitoring and follow-up. Just one thing to mention is fetal movement is a great indicator of the well-being of the fetus, and there is still a practice of keeping a log at various weeks leading up to birth, because if some physicians believe that if there's a drop in activity, it may be worth quickly following up, especially at the point when we're talking 28 weeks in. A fetus is typically viable as early as sometimes 24. So at this point, if there is a problem that is correctable at 28 weeks or later, you will sometimes see the induction of labor or a cesarean section in order to actually potentially bring the baby out, fix the problem, right? So this is just an example of a very generic chart. You'd have this continuing all the way up through 40 weeks. So preeclampsia and eclampsia. Preeclampsia is hypertension and proteinuria. Okay, both of those things must be present. Commonly in the third trimester is when you see this, but generally it'll happen as early as the 20th week of pregnancy. Hypertension while pregnant is a major concern, but it becomes an even greater concern when you do have that protein in the urine. Now you have full-on eclampsia when a seizure occurs in this patient. So blood pressure will be greater than 140/90. Seizures are typically of that grand mal variety. Confusion, disorientation can also be present. You're going to see things like sudden weight gain, edema in the face, hands, and feet, headaches, pain around the upper central portion of the abdomen. You might even see visual disturbances and clearly the elevated protein in the urine. Next is abrupto placentae, is a medical emergency for the mother and fetus where the placenta detaches from its location. When a placenta attaches from the uterine wall, it causes hemorrhage, fetal distress, and can actually result in both mother and fetal death. The cause is often unknown, but things like infection, hypertension, trauma, and drug use are all major risk factors. Treatment, hospitalization, bed rest. Labor might be induced if the fetus would be deemed viable or bleeding is too much. They could also do a surgical delivery as well. Blood replacement can be needed if the hemorrhaging is excessive. If it is a much younger fetus, then the outlook is definitely a lot more guarded, and there's much less likelihood that treatment would be successful for the fetus. Placenta previa is when the placenta covers the opening of the cervix. So this is a very low implantation point in the uterus. Placenta expands, the fetus starts developing, and then the cervix opens. Well, or it doesn't open because it's blocked, right? So if the cervix is blocked, delivery can't actually occur. Luckily, though, you find out about this early on. By the end of this, by the second trimester, you're going to know that this is going on. You might see things like compromise of the fetal blood supply. The mother can experience shock because there can be bleeding. But a pelvic ultrasonogram that shows the placenta over top of the cervix is the big thing, right? So as the cervix begins to dilate with pregnancy, you get tearing of blood vessels, and that's when the placenta will actually start to bleed, and that's why you see these symptoms. If the individual has this is one of... if they have this condition and there is bleeding, this is one of the rare cases where things like daily activities and exercise need to be watched and potentially not performed. There's also pregnancy positioning things. So you really want the fetus to be in the so-called vertex or cephalic position. But other presentations do occur that make delivery very difficult. Multiple pregnancies also have their own challenges, becoming a lot more common, especially with the use of in vitro fertilization. So they have their own challenges again. The mother's going to be greater risk for preeclampsia. There's a much greater demand on the mother's cardiovascular system. So you're going to potentially see greater hypertension in order to supply the same amount of blood. The symptoms of things like urinary frequency, constipation, edema, heartburn, all of that happens earlier in the pregnancy because, again, you've got 2 or more developing fetuses in the same space that's normally only taken up by 1. So, you've run all the same risks, but you've now multiplied those risks, right? So complications with multiple pregnancies do occur at a higher rate.